Good evening, everyone. We will be talking about an open source digital health journey um, through which all three of us and our organization have been actually through this journey together, um, and would like to share some of the thoughts in terms of how we have gone through this and the things that we have learned along the way. I guess there is some important lessons that have come through which will be beneficial for everyone. We've already done the introduction, so I'll skip this. Go straight into the National Digital Health Blueprint. Based on our research, what we have seen and found is that the digital health systems globally have sort of moved from large enterprise systems towards a digital public infrastructure model. Large enterprise systems are more proprietary in nature. These are countries where everything is controlled by large enterprise systems. And then, you have countries where instead of large enterprise systems, there are multiple systems, but they are mostly imported, not really built in the country. There is very little governance. And if at all there is governance, that is very lightweight governance, basically to make sure that, everybody is playing in the system. And then the evolution has happened to fire-based registries. So there are countries that are having open source registries which are fire-based, and then the rest of the ecosystem is pretty much built around the fire-based registries. The most evolved in this framework are the digital public infrastructure for health. Pretty much the DPI concept came from India, where the India stack, or as we call it, the Aadhaar UPI stack, is something that started the concept of digital public infrastructure. DPI pretty much is like, the government has built roads and bridges for everyone to use. It is not owned by anyone. It is an open source, and it is free for the public to use. So that's the concept there. And built upon the DPI, which is there, India then built the entire health stack, which has evolved into the ABDM now, ABDM being the Ayushman Bharat Digital Mission. Ayushman Bharat is a Hindi word. In English, it's called the National Digital Health Mission. Is now serving as a reference architecture for the global DPIH initiatives. We'll talk about the global DPIH initiatives later on in the slide deck. Here is a journey of over 1.5 to 2 decades of digital health, and all of us have played a role in at different points in time, wearing different hats along the journey. India has gone through a journey of digital health transformation, starting with the National Rural Health Mission, and maybe even before that. But we sort of started recognizing the digital transformation in the National Rural Health Mission, where you had multiple healthcare IT system. Pretty much every vertical program had an IT system of their own. They were not really asked to do an IT system, but they felt the need, so they pulled out the budget and did it on their own. Each of the systems were built at different point in time with different technologies, little standard or no standards. So if you had to do any triangulation of the data, then it was impossible to do it at that point in time. So my favorite example is that if a low birth weight baby was born to a mother who had tuberculosis in the past, there was really no way of sort of tracing back that this baby probably had tuberculosis because or low birth weight because the mother had the tuberculosis at some point in time, because each of the data was in different system. The birth data was in different system, pregnancy different system, and the tuberculosis in a different system, and so on and so forth. So, it was in 2011 where we started working with the National Health System Resource Center and wrote a report called the Public Health IT Study Report, in which we recommended that Ministry of Health and Ministry of IT should get together to write up the digital health standards. In those days, it was called the e-health standards. And this was in the year, so the report came out actually somewhere in 2011. And then the 12th plan or the planning commission basically, put it into the 12th plan. And then the government changed after that. So we were wondering whether, this will be taken forward. But fortunately, it was picked up by the next government. And then, there were two committees that were created, an EHR standards committee and the metadata data standards committee. And both of these committees actually wrote up the standards, one for the electronic health records, and other one was more the nuts and bolts in terms of the data elements, the data libraries, the code directories, and so on and so forth. So I had the privilege of leading the task force that wrote the metadata data standards for health. So this was somewhere in the end of 2013, and then after that, again, the Modi government came in, and you see the trajectory. What happened after that? The standards were picked up, and there was a whole lot of consultations that were done across the board at the central level, at the state level, and there was a whole galvanizing of the different stakeholders that happened along the way. Fast forward to 2018, what happened is the national health policy came in, the national health stack was defined, and in 2018 the metadata data standards for health was notified, and then also it laid the basis for creating the Ayushman Bharat digital mission, and which happened later. So you see that red box over there. Now in that red box, and in the corner. So you see that the Ayushman Bharat mission happened, and in the Ayushman Bharat mission during the pandemic, the National Digital Health Mission was notified from the ramparts of the Red Fort by the Prime Minister himself, and then it was upgraded to National Digital Health Mission in 2021, and then the rollout of all these standards started in 2022. I'll talk a little bit about the digital health standards, and then my colleagues will talk about the digital health mission and the rollout, the way it is going on. In terms of the standards, it's actually very wonderful that it just happened the way it happened. The At the lowest level, if you see, it is the metadata and the data standards. So metadata is basically a library of about 1,000 data elements and 140 code directories. So these code directories are nothing but value sets that fit into the data elements. Now, data element is like a holder. So it is, you can think about it as a glass or a tumbler in which you have the data type and the data size. So it'll accommodate only the kind of data type that has been sort of designated, and it'll accommodate only those many characters in terms of data size. So each data element is for a different purpose. It is labeled differently because, based on the purpose, and the values that it will accommodate are actually bundled into the code directories. So there are about 140 code directories. Then you have the registry design, and then how you are going to bundle all this information into standard transaction formats and for the health information exchange. Of course, the governance layer is something that will have to be built on top. So MDDS was basically something that told us as to how to use the data elements. Take an example that for gender. So in Hindi, say, it is written as XYZ. In another language, it is written as 1, 2, 3, 4. In English, it is male, female, trans, and other. Now, if you were to interoperate, or if you were to do an interoperability between these three systems, how do you know that male is one or male is X or Y? There is really no way of mapping it. And that is the reason you needed a system which will provide you a standard list of data elements and value sets where you can do this mapping. And that was the reason this was created. Moving on to the next level, where we had the National Digital Health Blueprint. In the National Digital Health Blueprint, it is a federated architecture. It is federated because India is more like a subcontinent, with each state like a country in itself. The size and the diversity of India is huge. So, to accommodate that diversity, we had to create a federated architecture. Federating meaning that the data stays at the local facility level, and it is residing with the facility. It is rolled up to the state level and to the national level on demand for analytical purposes. But there is a whole lot of standards that are created around it to make sure that the data remains secure, it remains private. There's a consent-based mechanism to make sure that it is controlled and shared only for the purpose and only for the duration that is supposed to be shared. We'll talk about the DPDP Act as we go down the path a little bit more. Um, there was a report published by the Niti Aayog. So Professor Dennis Traveller and myself, we first wrote the concept of the e-objects in the Niti Aayog theme paper, Health System for New India. This book was published in 2019, and it sort of became the basis for writing up the National Digital Health Blueprint that we talked about, in which there were the provider side objects and the payer side objects. The provider side objects are basically for provider to provider interoperability, and the payer side objects are provider to payer interoperability. You can see those e objects, as we used to call it. Basically, very similar to fire or objects, which later on what happened is we picked up the Fire International and we sort of customized it for India based on the e-object concepts. So we have a library of fire profiles for India. These are for the provider side as well as for the payer side. Payer side, we have taken a lot from the e-objects because we needed the interoperability in terms of e-claims, and we needed the standardization on the health insurance side. This is a picture which really doesn't need any explanation. All the stalwarts, they released that book, The Health System for New India. Chapter 5 is written by Dennis Traveller and myself. And that sort of became a landmark in 2019 for creating the National Digital Health Blueprint. Over to Dr. Balaji to sort of explain the digital health mission.
So, the National Digital Health Mission has been the what I would like to call the National Digital Health Blueprint was the reference architecture, the vision, the Bible, so to speak. The National Digital Health Mission has been the design, the technical implementation, the core of the actual foundation on which the entire national digital health ecosystem, which was envisaged, has will rest on. And this is the nuts and bolts of the technical details, the numerous components put into action, so to speak, um, at a design and national level. So it is can be quite technically heavy. I will run through some things rather quickly because going through detail on this one could take a long time. Any questions, we can always discuss it in the question answer session or subsequently later, because this is very, very detailed. The state of digital health and the state of data within healthcare, um, it was severely exposed during the pandemic. We always knew it emotionally, we always knew it administratively, logically, but we never knew it like a punch to the heart, so to speak, among us clinicians especially. uh, we always believed that taking care of patient is an individual doctor's responsibility, and largely healthcare functioned that way in silos from a data perspective. Um, During the pandemic, a lot of things happened, and records not being available, all that we know. But what we couldn't envisage was the direct impact of administrative, supply chain, processes that are non-clinical, having such a huge impact on clinical outcomes. And this is where the pandemic really showed us. So everybody talks about interoperability of records, data silos, disease management, all of that. But if you think about it, nobody really talks about supply chain optimization. um, and that became very, very key during the pandemic. So we didn't know where beds were, we didn't know how many beds were available, how much oxygen was available, how many drugs had expired, so many other factors which then had a direct impact on clinical outcomes. And that is when it became blindingly obvious that we have to have an integrated system, an interoperable system, seamless system, whatever it took. And that is what triggered many of the subsequent things that happened over the last 5 years. I will just pause on this slide for about 10 seconds. Just look at it and understand that the top one was the one that woke us all up, so to speak. What I would like to focus on here is two things: one, the image on the right, and two, the top point on the left. um, The image on the right was the Prime Minister of India announcing the National Digital Health Mission on 15th of August 2020. Why this image, and why the Prime Minister in this image? Uh, so, for those, you may not be contextual to India per se, but uh, a prime minister in India can announce anything from anywhere, but there is a significant symbolic and cultural effect with respect to things and policies announced from the ramparts of the Red Fort in Agra on 15th August 2020. Sorry, in Delhi. Um, the significance is that when something is announced from that podium by the prime minister, which is every year, that is something that is usually of transformative impact. That is something that signifies dead seriousness in what is put out there. And for the prime minister to put the National Digital Health Mission, announce it on that podium, put it on par with defense, put it on par with so many other education, so many other factors that are usually seen as more important than something like digital health. So it was perhaps for the first time that digital health was put straight in front as a priority at the policy level. This is the key, the significance of that image on the right. And uh, I would like to bring your attention to the telemedicine practice guidelines, um, because that, in hindsight, was the seed for enabling the cultural acceptance across the country of digital health. That was the actual, literally the trigger point, because the pandemic forced us to do that. Both clinicians and patients had to work with, deal with non face to face interactions, and they learned how to do it pretty quickly. And therefore, those telemedicine guidelines immediately opened the floodgates to access to healthcare, quality healthcare, reducing the cost of healthcare, and improving the quality of healthcare. Almost like the Holy Grail was seen as in a seed stage. And that this was a policy again that formed a core of the NDHM announcement. So, National Digital Health Mission, and later renamed as Ayushman Bharat Digital Mission. This is the National Digital Health Mission design and technical implementation stack. And it's a very, very dense slide. It is extremely complex and detailed. But let's start so, and I will go through it in detail in subsequent slides. So it is basically made up of four layers. The the uh, the bottom layer is the infrastructure, the digital public goods. which is non-healthcare related and can be used for healthcare. So in the interest of bandwidth, I'll just put off my video. Yeah. So the bottom is the digital public goods, not related to healthcare per se, but forming the foundation and experiential background of what came later. The next layer is the health data exchange layer, which contains digital registries, health information exchange, health claim standards, and all of them I'll go through in a little bit more detail in subsequent slides. The penultimate layer is the unified health interface for syntactic interoperability, which includes all the APIs, multiple service APIs, multiple discovery APIs, multiple consent management APIs, all of those things. So, and the last layer is user applications. Now, again, 10 seconds on this slide for everybody to digest on a 30,000 feet level. Please don't look at the details, it will be very difficult. But just look at the slide from the 4 categories that are on display, the 4 layers of the whole stack. And all of this, or most of this, has been done in India in the last 5 years. That is the scale and speed of the determination by the policy holders, by stakeholders, by committed individuals. It has been quite a journey.
And the beautiful thing is that all of us have played a role in making this happen, wearing different hats at different points in time.
Yeah, it has been quite a journey. So maybe, for example, I can give an example later. Okay. So with respect to the registries, which you saw in the layer related to health information exchange, we have a few registries, and I would like to go through it. Again, please understand, this is a federation of countries, that is India. Each state is like a country, and therefore there is a central spine needed, some sort of core central top-down approach with respect to data standards, with respect to being able to map all of the various data elements, the various systems, the country, to some sort of common language. So the first thing is the Ayushman Bharat health account number, which is a unique health ID for every citizen, every resident, every citizen, and this is the patient identifier for for exchanging patient records. I'll keep it that simple. We can go into details later if necessary. Then there's the health facility registry, which is a unique digital ID for all the health facilities. And the reason why this is necessary in India is health facilities in India are very difficult to pin down. Geographically, it can be very difficult. By pin code, it can be very difficult. Clinics can change doctors' clinic can change, individual doctors' clinic can move based on rental situations. So all of those things require this health facility registry and the unique digital ID associated. So irrespective of almost where they are, as long as they have the unique digital ID, they are recognized as the validated certified entity with respect to certain patient records and certain services. So to that extent, because of the size and scale of India, this is a critical portion of our digital health infrastructure. Then the healthcare professional registry, which is easily understood. It's a unique digital ID for all licensed healthcare practitioners. It's not a very complex thing. All of these things set up a central discoverability set of repositories. In short, so the next set of slides are going to be talking about health information exchange and health claim standards. So we finished digital registries on the left, and we're going to the right of the same layer. So these are the health information data exchange components. The key terminologies here within the Indian context, and this could change based on country to country. The health information user, which is an entity that requests to view a patient's health record. The health information provider that holds and generates a patient's health records. The fiduciary, which is a unique concept in India. That is the entity that holds define the roles and responsibilities to ensure data is handled securely and responsibly. Now, um, this is a custodian of the security and privacy of the data. If you have to put it in the terms of the Western world, it is a custodian of HIPAA. So this is India's HIPAA, but there is a custodian for that. So somebody or some a few entities or multiple entities which are entirely responsible legally within the legal framework for the security of and privacy of the data, including exchange of data. And this is worth pondering over for a while as to the value of it versus not having something like this. And this is a point of view that could be discussed subsequently. Finally, the National Health Claims Exchange, based on the e-objects that you just heard of, that has proved to be somewhat of a game changer for India in the sense that has triggered the initial catalyzing of the national digital health ecosystem. The National Health Claims Exchange is contributed by many insurance players in the country, including the third party TPAs. And they are driving the exchange of health information. They are driving the exchange of health records seamlessly between providers. That is one of the key outcomes of these last 5 years. It has just recently been launched and recently put into action, so to speak. Finally, we'll go the key data element and the code directories, which are the absolute core of all this. These are standards that are international standards. They are open source standards, and they are by definition open content and open standards. Again, the MDS data elements is one of the key foundations in terms of few healthcare data, but also in terms of making the FHIR profiles, international profiles, specific to this country, and they're generating FHIR India profiles. Both these together came together to help the country generate very customized FHIR implementation. Again, Pankaj, just wait about 5 seconds on this for people to absorb 10 seconds. Because there are international standards below and customized national standards above. And if you see, most of the international standards are clinical, and therefore, the implication or understanding should be the most of the standards that are customized is administrative or process or supply chain related. And I'd like to give an example here. So, for example, India has boat clinics. India has Mela clinics. You will not find these terms or these codes anywhere else in the world. And these are the types of specific country specific, culture specific context that has to be brought into healthcare administration, and sometimes in healthcare in clinical healthcare as well. This is the reason why every country should have its own at least administrative / process, healthcare process management / healthcare business management data elements and code directories. This was
As I
our
like to
learning
say
as
that you cut the shoe to fit the foot and not cut the foot to fit the shoe, something like that.
Yeah, exactly. And finally, we come to the unified health interface, which is all of the APIs, which result in discoverability, which result in actual health data exchange. The three sort of components that there are a lot more, but essentially I've talked about the FHIR e-objects. I'm not going to repeat it. It is a country-specific implementation of FHIR. The consent manager is the traffic control system, as you see there, and it is key to managing patient consent. And there are many ways of implementing this. This is an ongoing process in India as we find the best way. It's a complicated scenario. Consent, informed consent, clearly communicated consent, consent based on acute episodes, chronic episodes, acute visits. There's a whole host of things that go into this, which can be talked about subsequently or in further discussions. And finally, classic personal health record, PHR app, ABA app, other private sector apps. The government has also brought out an app, other private sector players also brought out apps which leverage all the layers that we've seen before. Yeah, and I will not talk much about the bottom layer. Most people will know, hopefully, what our Aadhaar system is, the biometric identifier system across the whole country. Then the unified payments interface, which has been such a raging success in India to the point where even a roadside vendor has a QR code and payment accept payments through this interface. And the DigiLocker, which is a secure locker for sharing of verified documents, including health documents. But this is a standard government initiative. Now, coming to DPI for health. The reason for this slide is that what you have seen in the last, what do I call, 13 years in the original slide, the journey that all of us took to get to help India get to this place, and it has been a hard journey, has culminated in these three major initiatives that have happened in the last 2 years. All that we have talked about clearly came out in these three initiatives that arose after numerous discussions across the globe, practically. And I would like to start from the bottom, the Oxford Open Digital Health White Paper, which is labeled as a full stack remedy. Full stack is standards, technologies, architecture, and content. And this came out in 2023, when after all the 2022 initiatives were completed, followed by public health white paper by the Linux Foundation, which was an open architecture for health data interoperability, and we co-authored this, were extensively quoted in this. Uh, I don't know how to put it without appearing um, too assertive. Other than that, everything that we have done in open source has gone into this. And finally, probably as a direct result of this entire journey, Dr. Gupta was invited to represent LSRF on the WHO ITO working group for digital public infrastructure in health. And I'll let him talk about it a bit more if he wants to right now, or you want to reserve it for later, up to you.
Yeah, thanks, Balaji. Actually, the work is still going on, and many of the people from the ASEAN region are also part of it. So the wonderful thing is that the recognition that ABDM is getting as a reference for country level transformation. Now, there was a time when we used to struggle to explain it even within our own country, but it is music to my ears when I sit in these discussions at WHO ITU level, that ABDM is seen as a reference standard or reference country level transformation. So the work is still going on, and as things progress, I'm sure it'll get published at some point in time.
So open source, and this is the core of the discussion around open source. And open source is a single word, but it can mean in a whole lot of things in terms of how is open source implemented. And it can mean open source is a free for all, where every code is taken and just used indiscriminately, or open source is a completely closed system where everything that is done on that has to be put back into it, and there can be complete chaos if this is not properly set in place before implementation begins. So India had put an open source policy by the Ministry of Health and Ministry of IT, actually, mandating that certain key components of India's digital health stack, certain key components of the NDHM implementation have to be open source as defined by the ministry, which means some degree of code openness, some acceptable license models, etc., etc. So that was put in place. But what I would like to focus on is the various licenses that are available in open source, and how to choose what is best for your country, given the current scenarios in your country or your region, as you deem fit. And there are three. We have divided into three categories: the most restrictive, the middle, the compromise, and the least restrictive. And I'll start with the most restrictive first, the GNU General Public License and the GNU FRO General Public License, AGPL. Both of these ensure that whatever is done on the on the code that is labeled as open source has to go back to into open source. There is absolutely no way of commercializing anything whatsoever. And though this may prevent completely vendor prevent lock-in, but it also prevents economic growth. It is not a balanced view as to how to get the best of both worlds, both of private sector innovation and IP and of open source. These two have to dance together. Otherwise, they will pull each other down, and I mean literally pull each other down. And we have experienced this as multiple in multiple countries, which go one way, then go the other way, not realizing that there has to be an equal balance between these two typically opposing systems of software. Next.
In the interest of time, Dr. Balaji, I think we can talk about what is recommended. Um,
Okay.
and
Oh,
yeah.
time is running out. Sorry, I get too involved. So the compromise layer is what is critical, what we call the Mozilla public license, where it is the file level copyleft, is a sense that any modifications to the files labeled as open source have to be put back into open source. Anything other than that can be commercialized. You can put layers of a top of it. You can use the files without touching it, and it will allow you to both innovate and plow back into the community. I'll keep it that short. Go ahead. And finally, we have the most permissive or the least restrictive, where everything is free for all, which is not very practical and very good in terms of the ecosystem. Over to you, Pankaj. Sorry for overrunning. I got too involved.
That's fine.
Apologies.
Absolutely fine. Yeah. Okay, so quickly, the important aspect about privacy and security, that is something that is in top of a lot of people's head when they talk about the digital public infrastructure, because it is freely shareable, it is open source. Yeah, so the code is open source. The building blocks are something that are freely available. But what is actually not really shareable is the data, the person or the patient's data. So that has to be protected. So the DPDP Act is the latest one. It is the as Balaji sort of put it, is the HIPAA equivalent in India. So it has four important components. One is the data ownership. So it very clearly says that the data is owned by the patient now. Everybody else in the ecosystem is a custodian or a fiduciary. The second one is that it formalizes the consent mechanism. In consent is that for the transactions, every transaction, so there has to be a consent that has to be taken in terms of for the purpose and for the duration. The blanket consent model is already gone, so that doesn't exist any longer. In terms of fiduciary, Dr. Balaji has already spoken about it. I'm not going to elaborate on it more. And there are very heavy penalties that are there in case there is a non-compliance in terms of keeping the data safe. There is more detail, but in the interest of time, I'll skip this and we'll go to the National Digital Health Ecosystem. Over to you, Arun, if you can
Yeah,
quickly.
thank you. I mean, thank you for all the explanation, and I hope so. I'll be very brief. All digital health ecosystems are essentially continuums and have three essential forces. One is the population health, which drives it. The other objective is the supply chain optimization, and the third one is the payer side, which is the universal health coverage. And these are interdependent and they need to interoperate, and therefore data quality is very important, and therefore the entire ABDM and the National Digital Health Blueprint, the metadata and data standards to enable that interdependence and interoperability to happen. At the same time, healthcare continuums are continuing to evolve, and systems need to be able to respond to these these changing evolution of the healthcare continuums. So perceptions of healthcare continuums are based on one's own role and therefore essentially limited to whatever your role is within stakeholder. But all health is eventually public health. Yeah. So the first element is the population health and disease management. I think the pandemic gave us some very important lessons on why population health is so important. I mean, because we did not have medtech and health tech data standardized and available real time, so there were no chance to create heat maps, or there were no registries, and things would have been far simpler if we had registries in the round one. But that's a lesson that was driven home the hard way. Then there is the payer side, which is always interested and should be interested in keeping the beneficiary alive longer and minimize their payments on health, keep the hospitalizations to a minimum. So population health would span everything from disease surveillance to provisioning to drug design and development, supply chains, outcomes for health financing and research. It's a very vast area, but a very key area. So essentially, the longitudinal health record becomes absolutely central to it. So authentic and near real-time data is absolutely critical. If we go to the next slide, it's about supply chain and supply chain optimization is extremely important. We learned that through the pandemic. Again, we keep coming back to the pandemic, but it was a very important lesson. Yeah, and we did not know where the beds are. We did not know whether there was adequate oxygen, where it was to be provisioned properly. Provisioning was a huge challenge, and provisioning remains a challenge in healthcare supply chains, even in normal situations. But we all need to be mindful that given the kind of conditions that we operate in, with all the nuclear, chemical, biological threats available, man-made or organic disasters can happen. We may be required to respond to emergencies again. But in any case, emergency or no emergency, deployment of resources, be they beds, be they ambulatory services, be they human resources or drugs, consumables, is very critical to healthcare ecosystems. Again, the payer side, universal healthcare coverage is a very strong financial lever that has been proven, and we are learning. It is being underlined every day in India, with the insurance industry taking great interest in seeing that digitalization of healthcare system happens. So if you see that the PMJAY coverage is over 40% now, health insurance has crossed the 50% mark, and claims are set to go up by 10x, and insurance has already started driving the healthcare exchange that we had talked about. Coming to the next slide, the e-objects are essentially what carry information into the health claims exchange. We've worked very closely with the NHA and the IRDA to make this possible. And this helps claims being processed as smooth as the UPI payments that we talked about, and except that it carries a much higher level of complexity than BFSI or retail. The National Health Claims Exchange went live recently, and it's working well. Then there is a huge opportunity for healthcare wallet, as we said. Good two early examples are Paytm and GeoHealth, that now have the healthcare ID and EHR linked to their thing. And if you look at the diagram on the right, there's tremendous potential for healthcare costs to be covered more comprehensively, and a lot more services can be covered in the digital health ecosystem. Finally, innovation is very critical to digital health ecosystems evolving in countries. The next slide, Pankaj. Yeah. So there is an innovation gap that needs to be covered, and what we did as a team actually sort of facilitated innovation a great deal, from design to deployment. We provided the building blocks which took out the technology risks for innovators. We provided mentorship, which bridged the expertise gap for innovators. As you all know, digital health is a converging domain, and skill sets are very complex for it. You don't come into it with all the skill sets. We ran the market access program for the National Digital Health Authority, which was actually to catalyze innovation and procurement. And then finally, we also put up the concept of the certificate of the stamp of confidence, which builds trust between the product and the user, making adoption better. So the risk and expertise gaps were all covered, provided new opportunities for innovators. This is a very critical, one of the questions in the questions was, what really is critical. I think, allowing innovation to play a part is very, very critical. It's a long drawn process, but clearly the policy standards and authorities, regulatory authorities are all in place. Rollout will happen over time, which is natural. And some of the real life implementation cases Pankaj will discuss in the next phase of the presentation. Over to you, Pankaj.
Thanks, Arun. In the interest of time, I will rush through a little bit, but I think Dr. Balaji and Arun have already laid the foundation of what I am going to say here. A lot of people have asked me that, okay, these are beautiful books, these are standards, they are good to sort of keep on the shelf and refer to them whenever required. What next? And then, they've said, okay, an authority is done, a standard is done, a policy done. What next? So, what has happened in the last 2, 3 years, actually 2 years, is that we've been able to take it to the ground level. Here's an example of one of the things that I was myself involved in. So, this project is where we built a platform to do implementation of everything that we have seen so far, all the standards, all the building blocks, and the DPIs, the DPGs, and we implemented it in a high mountainous terrain for a religious yatra, or a religious yatra, as in when people climb to the mountain to actually meet the or pay their homage or to the god, and that's like uh, they have to climb, and it's the climb is actually the most difficult part when you have to go to the temple, and a lot of morbidities and mortalities happen along the way. So we built a platform to actually figure out as to who could be the high risk pilgrims. So there's a system where the people can register before they start sort of the yatra. When they arrive in the location, the system comes alive. They get to know that the person has arrived in the area, and the high risk ones are given the wearables, and the lesser risk ones are having the mobile and RFID tags so that they can be tracked all along the yatra. And there is a dashboard at the back that constantly figures out the vitals, and if there are vitals that are going out of sync, then it is flagged. And there are clinics all along the way. Each clinic has an EHR and the point of care devices. These all clinics, the wearables, the RFID tag, the mobile app, everything is integrated into a single system at the back, and the system is constantly monitoring what is going on. Imagine the size and scale of this was a huge challenge for us. 50 lakh yatris, actually 50 lakh is 5 million actually. So 5 million people visit every year for the yatra, and about 500,000 were people who took the benefit of the platform. This is an open source platform that was published, and it has all the standards built in, tested in high terrain. It is available for other use cases like a hospital outside a hospital, in terms of home care, step down care, remote patient monitoring. It can be used for large primary care networks in a statewide or a countrywide. A smaller country, in India, a state is like a country. A smaller country could use it for all the primary care implementation in a single network. It can also be used for large human congregations in terms of conferences, sports events, etc. Um, in terms of architecture, I have more detail, but I'll not go into it because the audience is not technical in nature. We can have those discussions, but the idea is that bring all the data together so that we can put it into a data lake, and predictive modeling can happen, an AI based predictive modeling. Everything that we talked about creates a very good substrate for AI to come in and do the data analysis, and we've tested it. the way we structured the data, we structured the platform, the data that came in, we could analyze it, and it proves that everything that was done lends itself very well for AI based implementations. Again, a slide, I'm not going to go into it because we have already spoken majority of the things here. Last but not the least, we've done a lot of capacity building. We continue to do that because for all the projects that we do, we need capacity. We need people who are crossover between healthcare and technology, and that doesn't exist in the system. So we've done that a lot with universities in India. We would be happy to do it with the universities and organizations in the ASEAN region. So we are open to collaborations with the universities for capacity building, events, for consulting, etc., in the ASEAN region. With that, I think we are done with what we had to say. Thank you so much. Open for questions.
Thank you, Dr. Pankaj, Dr. Balaji, and Arun. Very, very powerful webinar. Thank you for gracing our webinar tonight. We have a lot of questions, and some of them you have answered already in the chat box. So I'll go to from the last question from Raj Pudel. Does the software or system managed, maintained, and developed technically by government hired staff or outsourced to other organizations? Over.
I'll take that question. Thank you, Alvin, actually, for the kind words. And we are very thankful for giving us the opportunity to actually speak on this forum. To answer the specific question, government, does not manage anything. The only thing the government has done here is laid down the standards, the building blocks, the frameworks, and there is a national digital health mission to oversee the implementation is going in the right direction. It is not mandated for anyone to adopt. They should see the value in adopting it, and then they should adopt it. So there is really no policing, so to say, and the management of it is not done by the government at all. It's an open system. It's been published and in open source. Anybody can pick it up, use it, build upon it. um, so yeah, the only thing that the government has done is that the on the DPDP Act, which is the data, the patient data, so that is where they are being very careful that it doesn't get leaked or misused. Other than that, everything is open.
Thank you very much. I also saw the slide about the Prime Minister making very important messaging. I think that's very important. When the people hear it from the leader that this is the way forward, that's a very good start for something as complex as this. From Professor Joshi from Digital Health ID, even though there is already an Aadhaar ID. So is there a separate ID for ABDM, or are you using Aadhaar ID? Number two, is the digital health federated architecture currently used for sharing information from all digital facilities? And number three, how does the university get involved in your digital health transformation? Over.
I'll take it one by one. Just remind me if I have missed any of those questions. First one about the ID. So there is an ABHA ID. ABHA ID is a national health ID that has been put out by ABDM. It is based on any government ID. Now, preferably Aadhaar, but any other government ID can also be provided to validate. It's the one-time validation that is required from a government ID, and after that, the ABHA ID can be used as a health ID for all health purposes. So you don't want to use Aadhaar for every time you go to a hospital. That is the reason, or every time you avail a healthcare facility or a healthcare function. So that is the reason ABHA has been created. It is sort of a layer on top of the national health IDs. Aadhaar being the main, but of course you could use the other state level government IDs also.
Is the federated architecture being used right now? Is it a federated architecture? Over.
Yes, it is a federated architecture. the central government, as we call it, the national government is called the central government in India, has laid down the architecture, the frameworks, and the standards, but the implementation lies with the state government. So every state is free to do the implementation their way. Healthcare is a state subject in India. Every state will obviously take this as a reference architecture and implement it in their own state. The data will reside with the facility. Every facility will own it in terms of being a custodian. And the ownership now has been given clearly to the patient under the DPDP Act. So it is federated to the extreme, actually. So the central government actually owns no data. The central government will have to request the state or the facility that you give me the data for so and so purpose, and for the purpose and the duration will also have to be specified, and the consent will have to be provided by the patient before it is shared.
And how were you able to organize the universities around this effort? Over.
So universities actually play multiple roles here. Universities are one is in terms of capacity building. I think I talked a little bit about it because at least in India now the new education policy is there, which is opening the doors. But the earlier education policy was very restrictive. You could only become a healthcare professional or an engineer if you wanted to do a crossover. That was just not allowed. Now the gates are being opened and the universities are coming up with digital health programs, which are starting with capacity building in terms of imparting the skills, and skill upgrades, skill development, then degree programs, and then research programs. Research programs are to universities could actually become the incubators and accelerators. They could be the place where new applications are developed, incubated, taken to the certification level, and then launched in the market. So universities have a multiple role to play in the ecosystem.
One last question from Krisha. Who maintains or updates the ABDM architecture model?
Very good question. Actually, you know, the version 1 was created and that is still being adopted by all the different states. The version 2 is in the works in the background now. Of course, there is experts. In fact, me myself, I'm a volunteer working with ABDM. And there are other volunteers, there are other people, experts who come and provide their expertise to continue to sort of debate and provide insights into how the next version should come up. And so far, it is the version 1. Now, there has to be a mechanism as the maturity happens, as the evolution happens. Of course, ABDM will come up with a mechanism to do the versioning, and how the versioning will be controlled, time will tell.
Thank you, Dr. Pankaj, Dr. Arun, and Dr. Balaji. We've run out of time, but I think we should have another session. Maybe choose a subtopic from what you presented and then go deep dive because I think the participants are very, very interested. And next time we will invite the insurance people from the emerging countries in Asia. So may I ask everyone to open their camera so that we can have a photo, and then while Charisse is preparing to take the picture, maybe Dr. Pankaj at the back, maybe offline, we can talk about. I really am very interested in the governance behind how everything moves forward. All were volunteering, government was light touch, but everything was moving in a certain direction. That's very interesting, especially in a country as big as India. Also the open source, I think that's another subtopic by itself. So we can have I missed some of the elements in the open source because we were rushing everyone, but I think we should have another session on open source. So if it's okay with you, Dr. Pankaj, Dr. Arun, and Dr. Balaji, let's have another session, maybe 2 or 3 more sessions if you don't mind. Thank you.
Thank you
Dr.
very
Pankaj,
much.
Dr. Arun.
Thank you
Let's keep in
all.
touch,
Thank
please.
you.
All right. Bye-bye.
Thank you, Alvin,
Thank
for
you.
making
Thank
it
you.
possible.
Yes.
Thank you
Thank
so
you.
much.
Thank you.
It's really
Very, very informative.
wonderful. Thank you. It's wonderful. Thank you.
Bye-bye.